there, my name is Dr. Hermine Creger, and I want to do a case study with you today about a mother and father's concern about their son that is shorter than his classmates. The parents of a healthy 8-year-old boy are concerned that he is shorter than his peers at school. The mother tells you that he was a full-term infant, has no significant medical conditions, and has been on target with his growth and development. Other than being small for his status age, his exam is normal. His upper and lower body segment measurements demonstrate normal body proportions. His father is 6 foot 4 inches tall and developed pubertal development at 13 years of age. His mother is 5'9", and she had her first menstrual cycle at 14 years old. So what is the most likely diagnosis? What tests are recommended? And what is the best therapy? We will start by looking at his growth chart. So the top graph is his height for age, and the bottom one is his weight for age. So on the left-hand side is the blue arrow, shows you that his height is 47, maybe just a little bit more than 47. And if you look at the top, his age at 8, and you follow it to the convergent point, which is at the blue dot, you will see that at his 8-year-old well-child visit, he fell right on the 5th percentile. Now he is more than 8 years old, but not quite 9 years old yet, and now the convergent point falls below the 5th percentile. And if you follow the red line up, you will see where it ends on the right, where he is, looks like more than 2 standard deviations below where he should be. The bottom one is his weight, which was 55 pounds, and his age, which was 8. And it looks like his weight stayed about the same from the 8-year-old normal well-child visit to this new visit, and that puts him about in the 25th percentile. So what does it mean? So general accepted definition of normal range is anything between those 2 standard deviations as shown in this graph above. So with his height of 47 inches and his weight at 55 pounds, his weight for age falls below the 5th percentile. That means that he is shorter than boys his age. His weight for age is in the 25th percentile. That means he weighs less than 25% of boys his age, and 75% of boys his age weighs more than him. This, however, is not concerning. So how do you approach the child with short stature? History and observation, anthropometric measurements, plotting the growth chart, physical examinations, and a good workup. Now, if a child is showing appropriate growth rates with appropriate weight gains, even if their height curve is 3% on the low side, or right at the 3 percentile, or even right on the 5th percentile, and he has an unremarkable history, normal examination, physical examination, the American Academy of Pediatric recommends against ordering screening tests, the keyword screening test, seeking chronic illnesses or endocrinological causes that would give you a reason for why they're on the lower end. And the reason is that only about 1% will actually yield an answer for you. So, the recommendation from the American Academy of Pediatrics says when the child falls more than 2.5 standard deviations off the normal growth chart, yes, you can do a workup. Or if there are suspicious features concerning for dysfunction of the hypothalamic pituitary axis, then yes, you will do a full workup. So what do we know? We know he has short stature because his height is 2.5 standard deviations below the normal for his age. He has no significant medical history, and he has normal parental height. So let's look at our differential diagnosis, because it is important to know the differential diagnosis, because that will impact your review of systems, things that you have to rule out, your clinical approach on what to order and not to order. So, familial short stature. That means the bone age equals the chronological age. Those are children that have parents that are on the shorter size. Dad may be 5'8" and mom will be 5'2". He's not going to be much bigger than that, and that is a normal finding genetically. Then there are genetic conditions like Prader-Willi syndrome or inborn errors of metabolism like Turner syndrome. Chronic diseases. Pituitary diseases can be secondary to blood cancers or radiation, hypothyroidism, celiac or inflammatory bowel disease, heart disease, or kidney disease causing growth stunts. Growth hormone deficiencies, secondary to underdeveloped pituitary glands or problems with the pituitary gland. Malnutrition, secondary to food insecurity or conditions causing cachexia. Then a big one, psychosocial stress, war, famine, physical or emotional abuse, gender identity problems, neglect, anorexia, or depression. And then finally, medications like steroids, anticonvulsants, and stimulants. So short stature is a diagnosis of exclusion when a child falls more than 2 standard deviations below the mean group. So here is your clinical approach. First, you have to know what the child's bone age is. So we determine that by taking an X-ray of their left hand. Very predictable development based on our risk size of the left hand. And that will tell us if you compare the chronological age with the risk age, and it will give you an estimate of growth potential. So if the bone age falls a little bit off of the chronological age, that tells you that this child has potential to still grow and is just falling a little behind. Then there is the calculation of the mid-parental height. So we kind of alluded to that already, that if mom is only 5'2" and dad is 5'8", most unlikely that that child will be 6'3" or 6'4". So you can calculate what his height should be based on mom and dad, and the calculations for boys and girls are there on the right. Then you have to compare their current growth with their predicted growth velocity. So again, very predictable development by age group. So for this child, he should be growing 10 to 14 centimeters per year. Finally, Tanner staging to evaluate for delayed puberty. And there are the stages for you on the right for review. So how do we determine if there's growth hormone insufficiencies? The most predictable way to do that is know your differentials, because that will guide your review of symptoms, as well as your labs and diagnostics that you will be ordering. So for the review of system, you have to know if this is congenital onset or pediatric onset. So newborns with growth hormone insufficiency are usually normal for size at birth, but may have had jaundice, periods of hypoglycemia, microcephalus, or midline craniofacial abnormalities like cleft palate. So normal at birth, and then here by 3 months, 6-month follow-up, 9-month follow-up, they fall off the chart. And that's when you start noticing the Prader-Willi syndromes or the Turner syndromes that you may not have been aware of. pediatric onset is usually our toddlers in school age. They show a decrease in growth velocity, especially in their long bones, and a failure to fall into the growth velocity for their age. So that's the child that instead of growing 10 centimeters a year, only grows 7 or 8 centimeters a year. Look for clues like poor appetite, unintentional weight loss, abdominal pain or diarrhea, vomiting, unexplained fevers, headaches, out of proportion height, or dysmorphic features like lower limbs that are more affected, or disproportional weight. Short fellows with that's kind of overweight. So, labs to order. We will do a CBC for anemia, a CMP to look for a hepatitis or liver dysfunctions, your CRP or ESR for chronic inflammatory disease, that's your celiac or your Crohn's disease, and also for electrolyte changes, and your thyroid studies that will tell you if there is hypothyroidism, and a urine analysis to see if there is a overlooked chronic kidney disease. If warranted, you can do chromosomal analysis for Turner syndrome. That's our little ones that falling behind on their growth charts. Insulin growth factor 1 and insulin growth factor BP3 are the two that you will order in the office. Those may be off, or they may slightly just be normal. So that is not diagnostic. From here on, you will refer them to an endocrinologist for confirmation, and they will order growth hormone provocation or stimulation testing. They interpret that. They read it and they interpret that. We are not doing that as nurse practitioners. And then also, if an MRI is warranted, they'll order it to rule out any tumors like pituitary tumors, if that is the concern. Treatment. So treatment will be with recombinant growth hormone, and it's indicated in all cases of pediatric hormone deficiencies. Treatment usually involves daily dosing and frequent follow-ups. This is a subcutaneous injection that they have to have every day for oftentimes years. The yield is very small because they, instead of growing 8 centimeters a year, they may grow only 10 or 12 centimeters a year. And then it requires frequent follow-up and testing, which can be very problematic for the family to keep that schedule. And then, of course, insurance has to pay for it. These are very, very expensive treatments, so insurance has to approve it. So on your side, you're going to manage the injections, prescribe them, do your evaluations in the office, physical exams, growth charts. But you're also going to manage the side effects. So you have to be aware of what the side effects are, and they are rather rare, but can include headaches, slipped capital, femoris, epiphysis, and peripheral edema. The dose is based on the skeletal age and maturation, and typically increased during puberty, then discontinued as they reach their skeletal maturity. Growth hormone increases height velocity, and children has the potential to meet mid-parental height range. So for our fellow, between his mom that's 5'9" and his dad that's 6'4", he can easily reach 6 and above. So allow children to be happy in their own way. For what better way will they find? I say this because being shorter can be emotionally and physically challenging for children, particularly because it exposes them to bullying. Children are not always very kind to each other, and they can be very honest about things too. So it is important that if you notice anything that is concerning to you, to discuss it with the parent and the child so that they can feel emotionally supported to avoid any emotional distress for them. Thank you so much for your time, and I hope you have a good day.